micro lecture where we talked about dislocations, and today we will be doing our part 2, which is some reduction maneuvers for certain fractures. This is again a micro lecture that is useful for your practical exam. So we will start with the clavicle fracture. We will do like last time. You are at the emergency room. We have the patient walking in. Again, he will be in the humble position when he's sustaining his injured arm with his healthy arm, trying to basically pull up his shoulder, trying to reduce the fracture, because most of the clavicle fractures are in the medial third of the diaphysis. So because of the muscle insertions, 99% of these fractures are displaced. So the patient is trying to reduce his displaced fracture. So you see the humble position of the patient. You know there's something wrong with his arm.
Excuse me, Professor, the slides are not moving. I mean, we're still on the first slide with the headline. Now you changed it. Yeah, now you changed it.
Yeah, because this is an introduction. I don't have, like, if my next slide is the reduction maneuver directly, so I'm trying to, yeah. I know the last time we had this problem too, but now I know what I did wrong last time.
Okay, perfect. Thank you.
I didn't upload the full screen, and that's why it was doing the problem. I'll leave it here.
All right, thank you.
Yeah, so I was saying you have the humble position and you look at the patient. Again, what I'm saying here should have been said at the lecture, so I'm just kind of doing a introduction / revision of what you did on the lecture to get to my point, which is the reduction maneuver. So you have the humble position. You look at after you put the patient on a chair and you look at the patient, you see there is swelling at the clavicle side. On the injured part of course, of the, let's say it's the right shoulder. So you put the patient on a chair, you look at the patient, you see there will be swelling on the right side where the fracture is. You palpate the clavicle, because the clavicle can be palpated just under the skin, and you will fall into a hole at some point. It's the pencil sign. When you move your finger on the clavicle line, you will fall in a depression or in a hole kind of area, at which point the actual fracture is. So you have your suspicion, your preliminary diagnosis, and you send the patient to the X-ray. You do an anterior view of the shoulder articulation, which sees the clavicle bone also. You confirm your diagnosis. You see it's displaced. As I said, most of the medial third fractures are displaced. So you know you need to reduce it. How do you do the reduction maneuver? You place the patient, as seen here, on a chair with no back this time. And you place yourself behind the patient. You put your knee in the back of the patient as a counter, and you grab the patient's shoulders with both hands and you pull them backwards and upwards. So the movement is backwards and upwards. So the chest remains in front, as you can see here. The patient has the chest in a not normal position. It's a forced position with his chest pulled in front, because the shoulders will be pulled backwards and upwards. So you actually reduce the fracture. And it is in this position that you start applying your bandage or immobilization, as you see in the picture. So the immobilization is the Watson-Jones bandage, or the 8-shaped bandage. As you can see, it's an 8-shaped kind of bandage, like as you can see here in the A figure. This slide shows you that there are multiple types of Watson-Jones bandage, but the classic one and the one we're using and the one we need you to know for your exam is this A figure, the 8-shaped bandage, 8-shaped bandage. This one. And so how do we place our bandage? Sorry, I'll get back to this slide. So as I said, the principle is you first need to protect the skin. In this case, the axilla are both the axillas are the soft spots here, the ones that can actually have multiple skin lesions and all sorts of other infection related complications. So you need to place cotton on the anterior side of both of the shoulders and through the axilla, as you can see here. So you have a surface that's in between the skin and the actual bandage itself. So you place cotton first on the anterior part of the shoulders and through the axilla. And then you start your bandage. So you're the examiner, as in this picture, you're behind the patient, you have your knee still firmly in the back of on the back of the patient. And you have your bandage in your hand, and you start your bandage from the posterior side of the patient, so from behind here, and you go upwards. It doesn't matter which direction, you can go left or right, but you need to go upwards on the anterior, then above the shoulder on the anterior side of the shoulder through the axilla, and then cross over upwards again to the other shoulder and do the same thing. Above the shoulder, anterior of the shoulder, through the axilla, and cross over. So this is one smooth movement that keeps on going and going and going until you feel like your bandage is strong enough so that the patient will not be able to move his shoulders forward. So the bandage needs to be strong enough to keep the patient's shoulders backwards, therefore keeping the reduction in place. One other thing you can do after you finish your bandage, as you can see, you either have a kind of like a cast or a belt or something placed here, or you can just do another bandage. So you tie the knot behind the patient here, and then you do a bandage which goes below to the actual belt of the patient, and you tie that bandage to the belt of the patient, which is like kind of like to reinforce the bandage and to prevent furthermore the shoulders of the patient from going forward and therefore reducing, losing the reduction of the fracture. Of course, after each reduction maneuver, you send the patient to the X-ray, and if it's okay, you send him home, and then you need to have checkups. The checkups are weekly, so once every 7 days. Every 7 days you have a checkup. You need to have these checkups for 3 reasons. The first one is to do an X-ray to obviously see if you still have your reduction in place. The second reason is because the patient, because of the fact that he breathes, the bandage can loosen itself, so it might need replacement. And the third reason is because most of the patients require this bandage to be changed each checkup because it loosens itself. When you replace the bandage, so when you take the bandage off, before placing the next one, there is a chance for the patient to do a local hygiene at the axilla region because he will not have access, as you can see. So there's a bandage here. He will not have access to his axilla for bathing and all other hygiene purposes. So the changing of the bandage is a good opportunity for the patient to clean himself up basically at that site. Another thing you can do is to prevent this reduction, to keep your reduction, is to tell the patient when he's sleeping to sleep on his back and to place a pillow under him, acting like the knee of the examiner. So basically you place the pillow, you tell the patient to lie on his back on the pillow, and so the shoulders will fall on the edges of the pillow, therefore keeping this not natural position with the shoulders backwards, so the patient will not do a certain movement during his sleep or her sleep, and will either break the bandage, loosen the bandage, or hurt himself, or other sorts of reasons through his sleep. In total, this bandage needs to be kept between 3 to 4 weeks. So you have the total period of immobilization of 4 weeks with weekly checkups. Okay, this was about the clavicle. Moving forward, moving to the fractures of the distal epiphysis of the radius. This is the most commonly encountered fracture in orthopedics, because whenever you fall or trip or whatever else, when you're going for the ground with your face, do not hit it with your face. You place your hands, so the hands take the hit, and most of the time the distal radius fractures, as you can see in these slides here. So this is the typical fracture. Again, you are emergency room, the patient walks in. The first thing you see is this S-shaped kind of arm, forearm basically, which suggests that there is a fracture at the wrist side. And again, if you palpate the radial line, you will hit a step. As you can see, there is a step here, which is the fracture site. Again, you see there is the radial line ends abruptly before the actual wrist. So there is a step here, and you can it suggests that there is a fracture at the distal radius. Okay, send the patient to the X-ray. Again, you need to do an anterior view and a lateral view of the wrist. Confirm your diagnosis again, and you need to reduce the fracture. To reduce the fracture, we first need to talk a bit about the displacement, because out of the 4 general displacements that you have, that you probably learn on your lecture or introductory lecture, this fracture has 3 of them. So out of the 4, there is 3 here. So, and each one of them needs to be reduced in order to do a correct maneuver, so the patient has correctly his fracture reduced. But first of all, how to position the patient? You need to position the patient on the examining bed this time, on his back, with the posterior side of the forearm towards the examiner. So you can see the examiner is looking at the patient, and there's the posterior part of the forearm facing towards the examiner, with the anterior part downwards. So the arm is, as I said, in this position. You place a bandage or whatever you have. You can do a cloth or bandage or some kind of counter, or you can even have a helper holding the patient's arm above the elbow as a counter, and another helper will have to grab the fingers of the patient with one hand. This picture is incorrect. Why I'm saying incorrect? Because how you need to do it properly, know it properly, and say it at the exam properly. And you also, in your books, if you read all sorts of material, you will see that this is not the correct placement of the hand. The correct placement of the hand is one hand on the second and third finger of the patient, and the other arm of the helper needs to grab the first, the thumb of the patient. You need to leave the 4th and 5th finger alone, because the ulnar nerve innervates that part of the hand, and so if you pull the 4th and 5th finger, you can cause complications of the ulnar nerve, like elongations and temporary paralysis of those fingers for the patient. So you don't want that. So you need to leave the 4th and 5th finger alone. You just grab with one hand, the helper, not you. The helper grabs with one hand the 2nd and 3rd finger, and with his other hand the thumb. while the examiner places his hand on the radial diaphysis, as you can see in this picture here. And now, before we actually start the reduction, as I said, we need to know the displacements. Out of the 4, there are 3 here. There is the longitudinal displacement, as you can see here, or the overlapping. You might have heard the word overlapping. So the proximal fragment and the distal fragment overlap, as you can see in the picture here. So longitudinal displacement. Second one is the angulation, as you can see here. It's either posterior angulated or it can be anterior angulated. And the third one has to do with this B-styloid angle. So the angle between a horizontal line and the line between the two the radial and the ulnar styloid, anatomically speaking, usually without a fracture, has a 30-degree angle. So the radial styloid is lower than the ulnar one. But when the fracture happens, the distal fragment of the radius moves lateral. And so the angle goes to around, as you can see in this picture, this is like a horizontal line almost in between these two styloids. So the angle goes to 0, which again, I would say big deal. It is a big deal because it prevents flexion. It prevents flexion of the hand on the forearm for the patient. So this is actually the most important displacement that needs to be corrected, because otherwise you can't do the flexion anymore of the hand on the forearm. And so as I said, we have lateral, we have longitudinal, we have angulation. The only one we don't have is the rotational displacement. And so having 3 displacements, we need to take them one by one and see how we can reduce them. So in total, doing these 3 maneuvers, we reduce the fracture as a whole properly. So as I said, patient on his back, you have a cloth as the counter, you have the helper grabbing the hand, you have the examiner grabbing the forearm with his thumbs palpating the distal fragment, as you can see in the picture here. And the first maneuver is traction. As you can see, this arrow here, the first direction in which the helper pulls is traction in the direction of the forearm, therefore reducing the overlap. This is one maneuver. While doing the traction, the helper will do a hyperflexion. So he will do flexion of the hand on the forearm with the examiner pushing the distal fragment with his thumbs in position. So reducing the angulation, okay? This is the second one. While being in the flexion position, as you can see here, you need to do cubital inclination, as it's shown here. So basically, as you can see, pulling the radial styloid downwards, remaking the angle, as I said earlier, right? So as you can see, it's pulling the radial styloid downwards, so the angle will be properly 30 degrees again. And it is in this position, so flexion plus the cubital inclination, in which we do our immobilization, right? So again, traction, flexion with the helper pushing the distal fragment with his thumbs, and then while flexion, doing the cubital inclination. This is the maneuver, the whole maneuver. And as I said, in this position, we immobilize. How do we do this immobilization? Because you can't keep your immobilization and do an X-ray. You need to place a cast before sending the patient to the X-ray. And how we do this, we place below the elbow cast, as you can see here. And we send in the correct position, and we send the patient to the X-ray. If the X-ray is not satisfactory for the examiner, so basically the reduction is not properly done, patient comes back, take off the cast, redo the reduction maneuver, and then again repeat the process, send the patient to the X-ray and check again. If the second time the reduction is not good, which it means it's an unstable fracture or a comminutive fracture or an intra-articular fraction, that a certain percentage of these fractures are unstable and cannot be reduced orthopedically, so you need to have surgery. So if the second time the reduction fails, you tell the patient that there needs to be surgical treatment done for his fracture or her fracture. Okay, but if the reduction is okay, is good under your immobilization, patient comes back from the X-ray and you need to complete your cast. So you need to put an above the elbow cast for the first 3 weeks. So if you send the patient to the X-ray is okay, the post-reduction X-ray is okay, you have your cast placed above the elbow with the elbow in 90 degrees flexion, and then send the patient back home. The first checkup here needs to be, the most important, I'd say, checkup here is the one that happens after a week from your reduction maneuver, because in the first week, the local swelling at the fracture site disappears, and also the cast might loosen itself in the first week, because there's, as you know, it's a heat chemical reaction with the cast, and the material still adjusts itself on the patient's forearm in the first week, so it can loosen itself in the first few days of the immobilization. So as I said, the most important checkup is the one at after 7 days. You do an X-ray, and again there are two choices here, two situations. The bad situation in which the reduction is hasn't been kept in this first week, in which case you need to take off the cast and redo your reduction as described earlier. So you redo your whole maneuver and immobilize again, and the 6 weeks start again from zero. Even if it's been a week since we immobilized the hand, if the reduction was not good, you redo your reduction and you start the 6 weeks again. And again, if on the second, so you call the patient after a week, the reduction was not good, you did the reduction, you immobilized, sent the patient again home, and again after another week, if the patient comes and again the reduction is not satisfactory, so the second time is not good, again you tell the patient that there needs to be surgical treatment, because again the fracture is unstable, comminutive. There is or even if it's just a simple plane like here fracture, a certain percentage of these fractures are just can't be reduced orthopedically, even if you're like the best in the world with reducing this type of fracture. Certain fractures just don't like orthopedic treatment, they like surgical treatment. Okay, but the other situation, you call the patient, as I said, after 7 days. You do the X-ray, and the X-ray is good, so your reduction is in place, is good. You check the cast if it's loose or too tight. It might be too tight. Some patients, if they don't do what they're told and basically keep their hands elevated, moving their fingers and all other indications from the orthopedic surgeon, they can have increased swelling at the edge of the cast here. So you need to check if the skin is properly, it doesn't have lesions, if there is not too much stiffness, or if the cast is not too tight or too loosened. And if everything is okay, you send the patient home and you call him again after 2 weeks. So basically you call him first at 1 week after your reduction, and then if that checkup is okay, you call him again after 2 weeks. So basically at 3 weeks after your reduction maneuver, at which point you will do again another x-ray to check if everything is okay, but also you need to cut the cast. So basically transform the above the elbow cast into a below the elbow cast, because elbows and knees immobilization more than 3 weeks cause stiffness. So you don't want that. So you need to lower the cast below the elbow and tell the patient to start doing movements with his elbow so the stiffness doesn't happen. Again, if that checkup is okay, send the patient home and call him again after 3 weeks. So at 6 weeks after your reduction for one final checkup, in which you take off the cast, do the x-ray without the cast, see if it's okay, and if it's okay, then you need to send the patient for rehab for his wrist, because the muscles and the soft tissues need to do some movements before they gain their full range of movement after removing the cast. Okay, and the last topic for today is the malleolus fractures and their reductions and immobilizations. Again, a bit of an introduction. As you can see, there are two mechanisms in which these fractures happen. Either inversion, so basically the foot goes inwards, or eversion, or where the foot goes to the lateral side of the thigh. I won't go too much into detail, but you should know this from the lecture. If there can be unimalleolar fractures, if only one of these malleolus are fractured, bimalleolar, if both of them are fractured, or there can be three malleolar fractures. There is this type of fracture described in books, but it's just described so it has for classification reasons. The third malleolus does not exist. The third malleolus, as it's called, it's just this posterior tip of the tibia here, as you can see, that sometimes fractures with these two malleolus. And so you have a trimalleolar fracture. This is a trimalleolar fracture called, even though there are only two malleolus, right? So, and each one of them requires a different, not a different, but a more complex type of reduction, and a different immobilization. So this is important why I have this slide. So you see there's one, it can be unimalleolar, bimalleolar, or even three malleolar fractures. Again, I need to do a bit of an introduction so we can you can understand better the reduction maneuver. So let's, as I said, there are inversion and eversion. The more common one is the eversion one, as you can see in this picture here. And how does the fracture produce itself? You have the foot going lateral, and so the medial malleolus fractures itself. This is the medial compartment is the one that's stretched, and so the medial malleolus usually fractures itself. If the trauma agent continues, the talus, which is this one here, because of the fact that it doesn't have any more stability in the medial compartment, will ricochet into the lateral malleolus, and it will most of the time break the lateral malleolus. If the trauma agent continues even further, the talus which is this one here, or this one here, not having any more stability in either of these compartments, will try to dislocate, as you can see here, posterior, and breaks the posterior tip of the tibia, the so-called third malleolus here. And if it does that, usually it dislocates posterior, as you can see in this picture here. The talus, I mean. So this is how a trimalleolar fracture with posterior dislocation of the talus happens. First one to break is the tibial one, then the lateral one, and then the talus dislocates posterior and might break the posterior tip. This is depending on how big the trauma agent. If it's a small or a short period of time of trauma agent, you can only have this one broken, the medial one, so that's a unimalleolar fracture. If the trauma agent is bigger, like let's say if something falls on your, like if you trip, that's a small trauma. So this is usually when unimalleolar fractures happen. If like something falls on your foot or your ankle, you usually get a bimalleolar fracture. Or if it's a high trauma like a car crash or other sorts of accidents like this, usually there is a trimalleolar fracture with dislocation. So depending on how big the trauma agent is, you have the bigger the more the fractures are basically. And so let's say you have the worst case scenario and you have this thing here. So the trimalleolar with dislocation, with everything going wrong for the patient. You have the patient being brought at the ER on a stretcher most of the time. When you look at the patient, you can see there is this abnormal angulation of the ankle. Local swelling. If you palpate the malleolus, there is pain at that site. On each of them, even the medial or the lateral one. And you have your suspicion that there is you have a suspicion that there is at least a bimalleolar fracture, even though this angulation makes you think that there is a dislocation also of the talus. But in the best case scenario, you have at least a bimalleolar fracture. Send the patient to the X-ray. Again, anterior view, lateral view you need to do of the ankle. You confirm your diagnosis. You have, as I said, the worst case scenario, which is this one here. And so you need to do your reduction maneuver. How do we do this? You have the patient lying on his back on the examining bed. I was remembering that I forgot to tell you. I'll come back to this. I forgot to tell you about anesthesia on the previous two reduction maneuvers. I'll come back to that. In this case, a local anesthesia won't be enough. You need to have either general anesthesia or the IV one that I told you last time to have muscle relaxation, because the patient is in pain. If there is a dislocation, the dislocation causes even more pain than the actual fracture. So there's a high chance that the patient will not let you do your reduction maneuver, and because of the contractions. So you need to have a bigger anesthesia this time, compared to the other two, which I will come back, as I said, at the end. So you need to have anesthesia. And the first thing you need to reduce is the talus, the dislocation. How do we do this? The maneuver you do here is called the unshoeing maneuver. Why is it called the unshoeing? Because it's actually like you unshoe yourself. I'm talking more to the girls here who have like boots and stuff. You know how you take off your boots? You place one of your hand on your calcaneus and one hand on your fingers, and then you just pull the calcaneal bone distally, and with your fingers you do flexion of the foot. So going basically bringing your foot to a 90 degrees angle with the tibia. So this is the unshoeing maneuver. You pull distally with your hand on your heel, and with the other hand placed on your fingers, you do flexion, basically doing a 90 degrees angle with the tibia. And so the talus will reduce itself at this maneuver. Good, so you reduced your talus. With reducing your talus, usually the posterior tip of the tibia will reduce with the talus, as you can see, because it's linked to the talus through a ligament. And after that, you need to reduce your other fractures, which is the lateral malleolus and the medial malleolus fracture. So after doing your unshoeing and reducing your displacement, you change hands. How do you change hands? You place one hand on the lateral aspect of the ankle on the fracture side of the lateral malleolus, and on the medial side, you need to have your hand placed roughly 5 centimeters above. So you don't want your hand on the same level. You want the lateral hand to be on the fracture side, and the medial hand, the hand on the medial side of the patient above 5 centimeters. And the movement you do is a translation. So basically you move your medial hand towards lateral and your lateral hand towards medial, right? So in the same at the same time, basically reducing your, as you can see here, you place one hand lateral, you place one hand medial, and the lateral hand goes medial, basically reducing the fracture on the lateral side, and the medial, the hand on the medial side will push the tibia lateral, trying to reduce again this fracture here. As you can see, the tibial malleolus fracture. So then this is called a translation. After your reduction maneuver, you send the patient to the X-ray, as always, to check if your reduction is properly done. Not before, again, immobilizing. The same as the distal radius. Before you do your checkup X-ray, you immobilize the thigh of the patient, and so you place a below the knee cast, send the patient to the X-ray, and if the reduction is not properly done, you start over again. It's the same principle at the radial fracture. If it's not, the reduction is not okay, you start over again. If the second time around is not okay, you need surgery. Same for the checkups. When you call the patient for the checkups, if the checkups are not okay, the first two ones, you need surgical treatment. But if the X-ray is okay, and you have, as I said, you have the worst case scenario, which is this one, you need to have cast above the knee. So after you place the cast below the knee, you send the patient to the X-ray, patient comes back, and you need to continue with your cast above the knee and keep it for 3 weeks. Same, again, principle as the radial fracture. After 3 weeks, lowering the cast below the knee because of the stiffness, and you can keep it up to 3 months. This is depending on how your checkups will evolve. Now, about the checkups. Again, the most important one is the first week one, where the swelling goes away, the cast still can loosen itself, and so you need to have that checkup. It's the most important checkup ever from your patient. If that checkup is okay, you send the patient home, you call him back after 2 weeks, so at 3 weeks from your reduction to lower the cast. If that checkup is okay, you call the patient back at 6 weeks. So after 3 weeks from your last checkup, at 6 weeks to see your reduction. Importantly, why is this 6 weeks checkup important? I'm sorry for the different language of this slide here. I keep forget to edit this slide. At 6 weeks, if your checkup is okay, you allow patient to do partial weight bearing. So basically, you allow the patient to step with his foot on the ground. And then after that, in the next 2 to 3 weeks, to keep weight bearing to continue his weight bear until he can do a full weight bear roughly a month after this checkup. Also at these 6 weeks, you can say how long you'll keep the cast. So if at 6 weeks the checkup is okay, most of the patients will keep their cast I'd say maximum for another month, but that's a bit too much. From my statistically speaking, they don't keep it that much. The book and the guides say to keep it 1 month extra, but usually after 2 more weeks, so basically at 8 weeks of immobilization, you take off the cast, because also it allows the patient to do his weight bearing easier without the cast than with the cast. After 3 months from his injury, you send the patient to rehab and start again doing his muscle training and all that soft tissue recuperation, so he can, again, to help him do the weight bearing properly. If you have, though, non-displaced fracture or a unimalleolar fracture, a fracture that doesn't require any sort of reduction maneuver, you can have a cast below the knee from the beginning, so not above the knee, that you can keep for 6 weeks. I'd say more 6 weeks than 8 weeks here. And you can allow weight bearing earlier than the more complex fractures, which require a bit more time for healing than this type of fracture. So again, 3 weeks and patient starts weight bearing, opposed to 6 weeks where the patient starts weight bearing. So simpler or non-displaced fracture gives the patient a chance to have faster rehab and faster mobilization of his joint. Okay, moving back to the anesthesia. So for your radius fracture, the examiner, before placing his hand and palpating the distal fragment and pushing with his thumbs, before you do your reduction maneuver, you need to do local anesthesia here. So the examiner palpates the radial line until he palpates the step here. As I said, there is a step here. And with him palpating the step, he will do local anesthesia 2-3 centimeters proximally than this fracture side. And he enters with his needle oblique in a 45 degrees angle through the skin and into the fracture site. How do we know we are in the fracture site? When we aspirate the syringe, there is blood coming back inside the syringe, which signals that we are in the local hematoma, which means we are we're in the proper spot. And so we inject our anesthetic. We let it do its effect for roughly 10 minutes, and only after that moment we start doing our reduction maneuver. And for the clavicle, again, we have the local anesthesia, because as I said, the clavicle can be palpated below the skin. So you just do, again, lidocaine or any other local anesthetic with the syringe. You just palpate, again, as I said, that you do your pencil sign, you palpate your hole, interruption of the bone line, and you inject the anesthetic there. Again, let it for 10 minutes to sink in, and then you start doing your reduction maneuver. Okay. I think that covers it up. Yeah. If you have any questions. If not, then your lecture will start at 11. So, and after that, I will, as I said, I will, while you're at the lecture, I will inform the examiners to see how we'll do with your afternoon lectures, to see we don't overlap with your afternoon lecture.
Should we stay on this link?
No, you go on the other link.
Okay.
We swap links because you were already on this link, so it was, yeah, not necessary to move around because, yeah, it's the same thing. I'd say go on the other link. If not, Dr. Nika will inform you on which link to go, but I'd say go on the other link.
Okay, thank you.
Okay, have a good day.
You too.
Thank you.
Have a good day, Professor.